the workup of CLL in the era of small molecule inhibitors. Currently the workup for CLL, I think you sort of think of things in terms of the diagnostic workup and the prognostic factor workup. The diagnostic workup is standard flow cytometry. That's not really changed. The workup for prognosis and predicting for outcomes, really we need to have that information before patients go on treatment. It's not essential when they're first diagnosed or if in the setting of not needing treatment. I like to have the information because it helps me to understand what to expect from a patient's disease and on an individual level. So I like to have the prognostic factors in patients who are recently diagnosed or newly diagnosed, although they're not essential. They are important when we are putting a patient on treatment, and the ones that we need to know these days in the era of small molecule inhibitors are FISH for 17p deletion, because those patients are higher risk and we perhaps manage them a little bit differently. TP53 mutation status, a similar situation, and that usually correlates with presence of 17p deletion. And then IgHV mutation status, we like to know because if a patient's young and is potentially eligible for chemoimmunotherapy, that can be helpful in terms of directing and choosing therapy. So the three are 17p deletion status, mutated TP53 status, and IgHV mutation status. The other ones that we historically have looked at are less helpful, and things like trisomy 12 and 11q deletion are really not very helpful in terms of directing treatment.